So the last topic that we're going to cover today is the assessment and management of patients with diabetes. And as I mentioned earlier in the endocrine disorders section, diabetes mellitus really represents a type of endocrine disorder, and it is usually an endocrine disorder that involves some impairment of insulin production or sensitivity by tissue with concurrent problems involving glucagon. So diabetes mellitus is a group of diseases characterized by hyperglycemia, that is the universal sign, and it's really caused by defects in either, as I mentioned, insulin secretion, insulin action or sensitivity, or both. It affects nearly 25.8 million people in the United States, and it is one third of the cases remain undiagnosed. So there's a huge undiagnosed population and an even larger diagnosed population. Unfortunately, the prevalence and occurrence of diabetes mellitus is increasing, and there's a real health disparities gap in terms of diabetes mellitus. Minority populations and older adults are disproportionately affected. So diabetes mellitus usually involves some dysfunction in insulin, as I mentioned, either secretion or sensitivity or both. Now, it's important to understand the normal function of insulin in order to understand the development of diabetes. So insulin does many things. It promotes the transport and metabolization of glucose for energy by insulin-sensitive cells, which include the skeletal muscle, the liver, and fat cells. Those are three key cell types, three tissue types that are sensitive to insulin. Okay? So it causes the uptake of glucose by those cells and the metabolism of glucose by those cells. It also stimulates the storage of glucose in the liver and muscle in the form of glycogen. So glycogen is just this huge polysaccharide that are individual glucose molecules attached to each other. And muscle storage of glycogen is for muscle activity, so for the use of muscle. And glycogen storage in the liver is actually designed to help support blood glucose in times of fasting. So in between meals, when you're not absorbing glucose, the liver breaks down glycogen and releases glucose to support, to prevent hypoglycemia. Okay. Insulin also signals the liver to stop the release of glucose, right? So when insulin levels rise, it suggests that you are in the process of absorbing glucose. You've just eaten and you're absorbing glucose, so the liver stops releasing glucose. Okay? Insulin also enhances the storage of fat in adipose tissue. It accelerates the transport of amino acids into the cell. Okay, so the muscle tissue takes up amino acids during times of high insulin. And insulin also inhibits the breakdown of stored glucose, protein, and fat. Okay? So insulin is really an anabolic hormone. It increases uptake of glucose. It increases the anabolic increase in tissue mass. Okay. There's a few terms to use to classify diabetes. The two most common types of diabetes is type 1 and type 2. They're very, very different disorders, and we'll define that in a moment. There's also a couple of terms to describe pre-diabetic stages. IGT stands for impaired glucose tolerance. IFT stands for impaired fasting glucose, or whatever. Impaired glucose tolerance is diagnosed through the oral glucose tolerance test. Impaired fasting glucose is an abnormal fasting glucose, right? That's what diagnoses that. So what the pre-diabetic label really depends on the diagnostic test. There's also a temporary diabetic state associated with pregnancy called gestational diabetes. We will, I'm sure, discuss that as well. But the key with gestational diabetes is that there wasn't pre-existing diabetes before the pregnancy, and that the diabetes resolves itself at the end of the pregnancy with the delivery of the baby and the placenta. Okay. There are also diabetic states associated with other conditions and syndromes. For example, acromegaly, which is an elevation in growth hormone, can also cause diabetic-like signs and symptoms, so hyperglycemia and other signs and symptoms. Cushing's disease can cause a diabetic-like syndrome with the elevated cortisol. So there are some other conditions, usually endocrine in nature, that can cause hyperglycemia and a sort of a diabetic-like state. Type 1 diabetes. Type 1 diabetes is a condition, it's a form of diabetes that involves what we call an absolute deficiency of insulin, which means that the pancreas is incapable of producing adequate levels of insulin. Okay? It usually involves autoimmune destruction of the insulin-producing beta cells in the pancreas. Okay? So it's usually an autoimmune disease where you have progressive damage and death to these insulin-producing cells. So a person with type 1 diabetes requires supplemental insulin because they have little to no insulin endogenously produced. So they are totally reliant on exogenous insulin. Now, the onset of the disease, right, the manifestation of the disease is usually quite acute because as soon as your insulin production falls below a threshold, your the hyperglycemia and the acute complications manifest very quickly. And it usually manifests before the age of 30. And what's very common is that the age of onset is a little close to adolescence. But you definitely see type 1 diabetics with an onset much, much younger. And you also sometimes see diabetics, a little bit more rare, but you see diabetics sometimes, type 1 diabetics, where there's an onset in middle age or much later in life. Type 1 diabetes really represents a small minority of total diabetic patients. So 5 to 10% of persons with diabetes are going to have type 1 diabetes. Okay. The rest of the diabetic population, 90-95% of them, have what we call type 2 diabetes. Type 2 diabetes involves a decreased sensitivity of tissue to insulin, okay, or an insulin resistance. Now, the insulin resistance involves those tissue types I mentioned earlier, so it involves skeletal muscle, the liver, and fat cells. They become less sensitive to insulin. So in response, the pancreas has to produce higher and higher levels of insulin to overcome that resistance. And that increased functional demand on the pancreas and the beta cells ends up causing chronic inflammation and chronic damage and impairment of beta cell function. Okay. So with type 2 diabetes, there's kind of two phases. You have the insulin resistance phase, and then you have the insulin resistance phase that involves compensatory hyperproduction of insulin. And then the second phase is the burning out of those beta cells and their inability to produce those high levels of insulin. Okay. And once that happens, that's when you tend to see this the diabetes and the hyperglycemia manifesting. So as I said, 90-95% of people with diabetes have type 2. The onset usually over the age of 30. Increasingly, we see children with type 2 diabetes, and the strongest risk factor for type 2 diabetes is obesity, which is why we sadly are seeing increasingly children with type 2 diabetes because of this child obesity epidemic that we have in our country and also in other developed countries. With type 2 diabetes, the onset is much more gradual. You tend to see a slow, progressive glucose intolerance. Right? And so you tend to see a long pre-diabetic phase before a person fully develops diabetes. Initially, it's treated, especially in the pre-diabetic phase, with diet and exercise. Diabetes mellitus, type 2 diabetes, is one of the only disorders that the pre-diabetic phase is completely curable with diet and exercise and lifestyle modification. So if caught early, you can completely reverse the process and avoid developing type 2 diabetes. And the diet and exercise modification doesn't actually have to be all that extreme. Someone can lose as little as 10% of their body weight, still be, by all definitions, still have an obese BMI, but lose 10% of their body weight and greatly improve the diabetic status. For treatment for type 2 diabetes, often insulin is used sometimes, and more insulin is used earlier and earlier in the treatment of type 2 diabetes. But a staple of treatment for type 2 are the oral hypoglycemic agents or oral anti-diabetic agents that help control the hyperglycemia, help prevent the hyperglycemia, and therefore avoid long-term complications of the hyperglycemia. So when someone is diabetic, whether it's type 1 or type 2, they manifest this hyperglycemia, this elevated blood glucose. Now, the nature of the hyperglycemia is a little bit complex. Okay? It might be a little more complex than you might think. So this person, this is an example of type 2 diabetes, this person has insulin resistance. Okay? So you look at this muscle, and the skeletal muscle has a decrease in insulin-stimulated glucose uptake. Okay? So this person consumes a meal, there's some glucose in that meal, they absorb that glucose into the bloodstream, but this skeletal muscle and those other insulin-sensitive tissue types don't take up that glucose because they have insulin resistance. Okay? So that leaves this this hyperglycemia. Now, there's a consequence to this. The liver, which also is insulin resistant, because it cannot take up because it can't take up glucose, the liver actually thinks that you're in a fasting state or you're in a starvation state. Okay? Because the liver has become insensitive to insulin and it can't take up the glucose, it actually thinks that you are in a fasting starvation state, and it starts to break down stored glycogen and release glucose. And this is going to actually worsen the hyperglycemia. Okay? So this hyperglycemia is due to not only a lack of uptake because of the insulin resistance, but also this elevation in liver glucose production. Okay? And this is important because those oral anti-diabetic drugs actually tend to act on the liver to reduce glucose production, okay? As opposed to supplemental insulin that enhances the uptake of glucose. But both drugs address this hyperglycemia. Okay. So both types of diabetes are associated with their own risk factors. So type 1 diabetes tends to be this early onset, and the risk factors are really more familial and genetic. Okay? So you're going to see type 1 diabetes in the family. You'll see a genetic predisposition. You might even see possible immunologic or environmental triggers. So certain childhood illnesses have been implicated in triggering the autoimmunity, latent autoimmunity that causes the development of the type 1 diabetes. So it's not that these viral infections are causing the autoimmunity, it's that the autoimmunity is there and certain infections seem to wake it up. Okay? So type 1 diabetes has its own set of risk factors. With type 2 diabetes, the risk factors are really about things like lifestyle and environment. So obesity is the strongest risk factor. Okay? Age, the older people get, the risk increases. Previous impairment of fasting glucose or impaired glucose tolerance. So any previous abnormal glucose test increases the risk for development of type 2 diabetes. The presence of hypertension increases the risk. The presence of dyslipidemia, so an HDL that's too low, or an LDL that's too high, or triglycerides that are too high. A history of gestational diabetes, or having a baby that goes over 9 pounds, which is somewhat suggestive of gestational diabetes, even if it was subclinical. Okay. Now, clinical manifestations for diabetes, there's acute complications or acute manifestations, and then there are chronic complications. Now, the acute manifestations, there are three key ones, sometimes called the 3 Ps. So polyuria, polydipsia, polyphagia. So polyuria means an overproduction of urine, and that overproduction of urine is caused by a hyperglycemia above the renal threshold. So blood glucose is above the renal threshold, which means that glucose remains in the urine, and that glucose elevates the osmolarity of the urine, and it traps water, and it causes this osmotic diuresis, okay, which results in the polyuria. The polyuria and the accelerated water loss causes dehydration and polydipsia, which is extreme thirst. And then the inability to take up glucose, even though they're hyperglycemic, the inability to take up glucose, especially by the liver, signals the body that it is in a fasting or starvation state. So polyphagia is extreme hunger. So oftentimes people, especially with type 2 diabetes, they're often very hungry. Fatigue, weakness, potential vision changes, tingling or numbness in the hands or feet, dry skin, skin lesions, wounds that are slow to heal, and recurrent infections. Okay? So all of these things are really the result of this hyperglycemia. The fatigue and weakness can be related to the dehydration. All of the vision changes, tingling and numbness in the hands or feet, those are the effect of hyperglycemia on the function of nervous tissue. So hyperglycemia affects or disrupts the function of nervous tissue, so you see those manifestations. Dry skin or wounds that are slow to heal, recurrent infections, the hyperglycemia tends to cause, tends to increase the likelihood of bacterial colonization of tissue, and it produces this situation where there's where you have recurrent infections and things are slow to heal. And with type 1 diabetes, you can often have a very sudden weight loss or unexplainable weight loss just before the onset of the disease. And sometimes you see that with type 2 diabetes as well. And really it represents this inability of fat cells and your body to take up glucose, and therefore the inability to maintain fat stores or build up fat stores. Okay. Diagnostic tests include, there's two major tests, actually there's three major tests. There's the fasting glucose, the oral glucose tolerance test, and the glycosylated hemoglobin, or the hemoglobin A1C. So fasting blood glucose, a normal fasting glucose, 12 hours of fasting, is normally between about 80 to 100 milligrams per deciliter. Between 100 and 126 is this pre-diabetic phase, impaired fasting glucose, and then 26 and above is diagnostic for diabetes mellitus. If you have a random glucose test, so fasting or not fasting, that is over 200, that is also suggestive of diabetes, but you need to confirm it with a fasting glucose. You have to keep in mind that as people age, you can actually see an elevation of glucose that does not mean that they're diabetic. Hemoglobin A1C is a blood test that allows you to measure the percentage of hemoglobin that has glucose attached. Now, the normal range for percentage of hemoglobin with glucose attached is less than 5%, but anything above that suggests a blood glucose level that is higher. The advantage of A1C is that it is, instead of just being a snapshot in time, that you have a single measurement of blood glucose. A1C, hemoglobin A1C, tends to reflect blood glucose over an extended period of time, between 2 weeks to 3 months, because 3 months is the lifespan of red blood cells. So it's kind of a more long-term, steady state reflection of what's happening with blood glucose. So treatment goals are really to have good glycemic control, to control blood glucose levels, maintain them at as close to a normal as possible. So the A1C goals are usually below 7%. Okay. Now, the thing to keep in mind, however, is that, so I told you that normal was below 5%. So therapeutic treatment goal is below 7%. So there's this accepted elevation in blood glucose when you're trying to control blood glucose. And it's the reason for that is the more intense the control of blood glucose, the more you run the risk of the person actually becoming hypoglycemic. And there are significant complications associated and risks associated with hypoglycemia. So having a treatment goal slightly above normal gives you a little wiggle room that prevents this hypoglycemic complication. Okay. So intensive control, defined as 3 to 4 insulin injections per day, or continuous subcutaneous insulin infusion, insulin pump therapy, frequent blood glucose monitoring, weekly contacts with diabetic educators, and all of these intensive control measures dramatically decreases the likelihood of the development of long-term progressions, like retinopathy that can lead to blindness, nephropathy that can lead to renal failure, and neuropathy that can lead to injuries and limb amputations. Okay? But think about that, this intensive control, you're taking a lot of insulin, so there's a chance for hypoglycemia. You are frequently taking blood glucose measurements, which in terms of money that's an expensive thing to do. Monitoring your glucose frequently, multiple times a day, is an expensive thing to do. Weekly contacts with diabetic educators. Okay? And often that's not the only thing involved in intensive control of diabetes. So it really takes quite a lot of work and vigilance and contact with your healthcare team in order to dramatically decrease or control your risk of these long-term complications. Dietary management is a cornerstone of good diabetes control. So people are not going to maintain a dietary management plan if they stop enjoying what they're eating. So they're not going to stick with it unless they can maintain this like pleasure of eating. We eat not just to maintain our bodies, we also eat to manage our emotions and our stress and to connect with family. There's strong cultural preferences when it comes to food. So all of these things really need to be taken into consideration when you are counseling people in terms of dietary management. Okay? Promoting exercise and activity is an incredibly important part of diabetes management. As we'll see in a little bit, exercise and activity can not only improve some of the risk factors in terms of promoting weight loss, but also exercise and activity improves the ability of your cells to take up glucose without the need for more insulin. So exercise is a really important part of diabetes management. Having a goal of a BMI of less than 25, which is a pretty tall order for a lot of people, but the focus really should be on improving BMI, even incrementally, because every increment helps. So not so much an extreme focus on getting people's BMI super low, but just improving their BMI. Preventing wide fluctuations in blood glucose. So this is really going to be about balancing the diet, the exercise, and the medications so that your blood glucose isn't constantly going up and down. What you really want is a nice, steady blood glucose as much as possible. And then decrease serum lipids if they are elevated, right? And diet and exercise can go a long way in that, through that goal. Role of the nurse. The nurse is key, okay? Diabetes management is about 99% patient education, and nurses do that. So be knowledgeable about dietary management. In fact, being a diabetes educator is actually a specialty that people are required to have a certain level of education and hours of patient contact in order to qualify as a certified diabetes educator, because there's so much to know. But really, if you're a nurse, whether you're a diabetes educator or not, you should be knowledgeable about diabetes management because it's so pervasive. Communicate information to the dietitian or other management specialists, reinforce the patient understanding, and support as much as possible the dietary and lifestyle changes. Meal planning. A person with diabetes is going to have to change how they think about food and how they plan their diet. So you might be counseling somebody who has really never done any meal planning in the past, but now really needs to. So meal planning to achieve good diabetic control, good glycemic control, you got to consider food preferences and lifestyle, the usual eating times, cultural and ethnic background. Okay, review the diet history. What have they previously been eating? Whether they need to lose weight or gain weight or maintain their weight. Calculate caloric requirements and caloric distribution throughout the day. Consider the carbohydrate to fat and fiber ratios. So their diet should be about 50 to 60% carbohydrates, but not simple sugars. They should be complex carbohydrates so that there is a much slower release of glucose. The stress should be on low glycemic index foods, meaning foods that trigger a more slow and gradual release of glucose rather than a very fast release of glucose. Okay. Fat should be about 20 to 30%, with less than 10% coming from saturated fat, less than 300 milligrams of cholesterol, and protein about 10 to 20%. Okay. Fiber, very important. Fiber, 25 grams daily, minimum. Okay, and what not just these percentages and the totals, but also the combinations of foods. Fiber and fat reduce the absorption rate of glucose, so making sure that they have a nice balance in each meal of protein, fat, fiber, and carbohydrates in order to help control that rise in glucose, to make it more gradual instead of very, very rapid. And glycemic index, really teaching patients about glycemic index. As I mentioned, glycemic index is a measure of how rapid a food leads to a rise in blood glucose. Okay, so foods that lead to a very rapid rise in blood glucose are things like table sugar, white bread. White bread actually leads to a faster rise in blood glucose than just eating table sugar. Okay. White starchy potatoes. So starchy foods, these foods they have a high glycemic index. Okay. Steering patients towards low glycemic index foods, and then advising them that they should be combining starchy foods with protein, fat, and fiber to slow down the absorption and improve the glycemic response. Okay. Raw and whole foods tend to have lower glycemic indices than cooked, chopped, or pureed foods. Okay. Eating whole fruits rather than juices. When you drink juice, you're getting all the sugar and none of the fiber. And when you eat fruit, you're actually getting far less sugar per volume and all of the fiber. Okay, and the fiber is going to slow down the glucose absorption. So adding food with sugars may produce a lower response if eaten with foods that are more slowly absorbed. Okay, so again, how are you combining foods? Other dietary concerns, avoiding alcohol is going to be very important. Alcohol doesn't have, has a glycemic index of 0 because it doesn't lead to a rise in blood glucose, but alcohol they are empty calories. And so if you have a patient who you're trying to improve their BMI, alcohol is essentially calories without any nutritional value. Nutritive versus non-nutritive sweeteners. So sweeteners that have a lower glycemic index, like agave instead of sugar or honey. Honey is a little bit lower glycemic index than sugar. And then sugar substitutes or artificial sweeteners, depending on how people feel about that, may be a good adjunct to their diet. And teaching people how to read labels, how to compare how to decide how much carbohydrate and sugars are in their food choices. So exercise. It is critical for good diabetes control. It lowers blood sugar. It promotes weight loss. It improves cardiovascular risk. So an exercise does not need to be an intimidating thing. You know, if you have someone who's mostly sedentary, getting them to just walk more, okay? Getting them to every hour that they are sitting to make sure they get up and they walk for 10 minutes, okay? So using things like pedometers or activity trackers can really help promote the stay active versus this sort of scary go to the gym and exercise mentality. Okay, so really any degree of activity, increasing a person's degree of activity, is going to have tremendous positive impact on their glycemic control and the control of their diabetes. Now, so there are some precautions, especially with type 1 diabetics or patients taking insulin, that need to be considered with exercise. So during an exercise, your blood sugar can actually increase as your metabolic rate goes up and things start to get broken down. But generally speaking, exercise actually reduces the amount of insulin that's needed. Okay? So making sure that patients are adjusting their insulin intake based on their exercise patterns, or adjusting their food consumption, making sure they're taking a little carbohydrate snack before moderate exercise to prevent hypoglycemia. Okay? And they really need to monitor their blood sugar before and after any kind of moderate exercise, moderate to significant exercise. Okay? With insulin therapy, insulin is an incredibly life-saving drug for patients with diabetes. It requires close blood glucose monitoring, because whenever somebody is taking insulin, you run the risk of hypoglycemia. Okay? And if someone experiences too many episodes of hypoglycemia over time, you can end up with really long-term negative effects. So insulin therapy involves the use of different forms of insulin that have different speed of action. So you have rapid-acting insulins. Your blood levels rise very quickly, and then they tend to fall very quickly. Short-acting, they only act for a short amount of time. Intermediate, so a little bit longer, and then there's very long-acting, where you don't get a big peak, but you get a low rise that's sustained, sometimes over 24 hours. And there's even inhaled insulin. Okay. So if we look at the pancreas's normal pattern of insulin release, what we see is this rise in insulin subsequent to every meal. So you consume breakfast, and then it causes a rise in insulin. You consume lunch, it causes an even slightly larger rise in insulin. You consume dinner, you get this even larger rise in insulin. So as the day progresses, your insulin response gets larger and larger, and potentially because your meals are getting larger. And then this sort of post-dinner snack, you get this tiny little rise. Okay? And then your insulin levels stay pretty low throughout the night before you get up and eat again. Okay? So this is your body's control of insulin release is so perfect and so well timed that the therapeutic use of supplemental insulin can't possibly come as close to this. It can't match your body's precision in terms of insulin release. But the use of the combination of these rapid-acting, short-acting, intermediate, and long are designed to try and mimic this normal pattern. So there's different insulin regimens that are recommended depending on how much insulin support people need. So this person is taking a rapid-acting insulin and a very long-acting insulin, right? So the blue dotted line, the person takes one injection that contains a certain amount of both, and the NPH, or the long-acting, is going to sustain them with some coverage throughout the day, and the rapid-acting is going to give them a boost right at breakfast. Okay? So this is a 1 injection per day kind of protocol. 2 injections per day basically repeats what the previous slide did. So at breakfast, they take 1 injection that includes a smaller dose of NPH, or the long-acting, right? And a dose of the rapid-acting. And then right around dinner, they have the same injection again, okay? A smaller dose of the NPH and a dose of the rapid-acting. And that allows for a little bit more support over the 24-hour period. And then you have more intensive insulin regimens. And these are regimens that involve 3 to 4 injections per day, okay? Where you can have, for example, several rapid-acting in a row injections, and then the last one also includes a long-acting to cover the entire nighttime period, okay? Or you can have 1, 2, 3, 4 injections per day, right? Where the first injection is a combination of the rapid and the long, the second injection is just the rapid, third injection is just the rapid, and then right around dinner time you take another long-acting again to cover you through the night. Okay? So what combination people are taking, what regimen people are taking, is entirely based on the their needs and what their clinician decides is the best kind of coverage that they need to control their blood glucose. Okay. Alternatively, you have patients, especially type 1 diabetics, who actually require a much more constant infusion of insulin. So they use insulin pumps. Now, the insulin pumps deliver normally a baseline level, constant level of insulin, right? Normally a longer acting insulin, to maintain a basal rate. Then, throughout the day, based on their meal planning and their exercise and things like that, they receive several boluses of the rapid acting. Okay? So using an insulin pump and having this kind of regimen really requires constant monitoring, because these insulin pumps, they can't both measure and deliver insulin. So the person has to actually be measuring their insulin, their glucose, in order to constantly adjust the pump as necessary. Okay? And as you can imagine, using a pump or using these more complex multiple injections a day regimens require a lot more patient teaching and patient monitoring. Okay? So there's a lot of self-management issues with diabetes. Really, everything is about self-management. It's sort of the theme with chronic conditions like diabetes. So we have to teach our patients the use and action of insulin. We have to teach them symptoms of hypoglycemia and hyperglycemia and what they need to do in both conditions. We need to teach them to monitor their blood glucose, the necessity of that despite the cost. We have to teach them how to inject insulin and how to use a pump if that's what they're using. Okay? And if you think about type 1 diabetics who are really going to be dependent on insulin, they're also, they're developing diabetes very, very early. So, think about having a 10-year-old who has an insulin pump and teaching them to use this insulin pump and monitor their blood glucose. So there's a lot of issues, especially in the pediatric world with type 1 diabetes, in terms of teaching patients and whether or not they are at a maturity level or a cognitive level to be able to learn and follow the directions. With type 2 diabetes, we start to see this use of oral anti-diabetic agents. And these oral anti-diabetic agents are often used in combination And they carry the same major side effect as insulin, hypoglycemia. So the timing of the oral drugs with, in terms of diet, meals, and exercise, it's going to be the same situation with insulin. It's not as acutely severe as we see with insulin, but it's still an issue. So in terms of nursing interventions, we're going to monitor glucose closely for any hypoglycemia or any other potential side effects. Okay, and again, there's a significant amount of patient education necessary for people to be on these oral anti-diabetic drugs and to reap the benefit and avoid the negative complications. Okay. So these oral anti-diabetic drugs, there's a variety of them, okay, and they all sort of act slightly differently. So some of them have, they all have sort of major effects and they have minor effects. So some of these drugs, okay, some of these drugs enhance, limit glucose absorption by the gut. Okay, so they control hyperglycemia by limiting glucose absorption by the gut. Some of them help reduce glucose production by the liver. Okay? Some of them enhance glucose uptake by skeletal muscle and fat. Okay? Some of them enhance insulin secretion by the pancreas, while some of them reduce glucagon secretion. And glucagon is the counterpart hormone to insulin produced by the pancreas. Glucagon's effects are essentially to elevate blood glucose. Okay? So by limiting glucagon secretion, we prevent that release of glucose. Okay? So all of these actions, right, all of these effects of these oral anti-diabetic drugs are to limit blood glucose in order to prevent hyperglycemia. So acute complications of diabetes and diabetes treatment, hypoglycemia, which we've mentioned, which is an acute complication of treatment of diabetes, whether it's insulin therapy or the oral anti-diabetic drugs. DKA, diabetic ketoacidosis, it is an acute complication of type 1 diabetes or type 2 diabetics who become insulin dependent, meaning they can't produce their own insulin anymore. Okay? But a DKA we only see with patients who are not producing their own insulin. Thirdly, the hyperglycemic hyperosmolar syndrome, or HHS. Sometimes you'll hear it HHNK, hyperglycemic hyperosmolar non-ketotic syndrome. With this, what we have, this is a complication of type 2 diabetes. And type 2 diabetes, they are not going to go into ketoacidosis, but they can be so hyperglycemic that the osmolarity of their blood increases and they can end up in a coma because of that hyperosmolar state. Okay? And if you look on your table 51.7, you can see a comparison of DKA and HHS. Okay? With hypoglycemia, you have an abnormally low blood glucose level. So we're talking for adults below 50 or 60 milligrams per deciliter. And remember, the normal fasting is between 80 to 100. So it's a complication of treatment. So too much insulin or poorly timed with exercise and food, or oral hypoglycemic agents, too much or poorly timed. Okay. Adrenergic symptoms. So when you become hypoglycemic, there's sort of two phases. The first phase is this adrenergic phase, meaning their sympathetic nervous system kicks in, and you start to see some sweating, tremors, tachycardia. You're hungry, you're nervous, you get a little palpitation. Okay, and these adrenergic symptoms are really important because they they're an important cue for you to know that your blood sugar is low and to stimulate you to eat something to bring it back up. Okay? If you don't consume any food, your adrenergic symptoms will progress into central nervous system symptoms. Okay? Blood glucose is critical for brain function. So when we have hypoglycemia for too long, we start to see central nervous system problems. Inability to concentrate, headache, confusion, memory lapses, slurred speech, drowsiness. Okay? You can have somebody who appears to be really drunk almost. Okay? But really what they are is very, very glycemic. And then when it becomes very severe, you'll see disorientation, potential seizures, loss of consciousness, and even death. Okay? Now, managing hypoglycemia, what you want to give this person is at least 15 grams of a fast-acting concentrated carbohydrate. So we have things like glucose tablets, right? Give them a couple of glucose tablets that increase your blood glucose very quickly. Give them some juice or soda, right? Not diet soda. We want the sugar. And you retest their blood glucose in 15 minutes to make sure that it's elevated. If it's not elevated enough, you give them more, right? You give them another snack, okay? And this, of course, assumes that they are conscious and able to consume the food. If the patient falls unconscious and cannot swallow, the preferred treatment is a glucagon injection. Okay? If you give someone glucagon, it will elevate their blood glucose and they'll regain consciousness. Also, giving some dextrose water, so 5DW, 25 to 50 mils IV, will also replace some of the glucose. Okay? If you don't have either one of these, you can actually put some of these fast-acting glucose, the glucose tablets or glucose gels, you can actually put it under the tongue and it will improve, some of it will get absorbed and it will improve the situation. But ideally, you are giving an intramuscular injection of glucagon and some dextrose water. Okay. One thing to mention about hypoglycemia before we move on, this two-stage consequence of hypoglycemia, the adrenergic symptoms that make you aware of your hypoglycemia, and then if you don't do anything about it, the central nervous system symptoms. When someone experiences hypoglycemia frequent enough, what happens is, unfortunately, that they start to lose this adrenergic phase. Okay? So if someone taking insulin, taking the oral hypoglycemic drugs, if they experience this complication often enough, this hypoglycemia often enough, their sympathetic nervous system adapts to this low blood glucose, and it no longer activates when blood glucose drops. So that means that they completely skip this adrenergic phase. Okay? And the first signs and symptoms of the hypoglycemia become the central nervous system symptoms. Okay? This process is called hypoglycemia unawareness, okay? Because they now have lost this adrenergic awareness phase that stimulates them to eat or gives them any clue of what's happening. So this person thinks everything is fine and then all of a sudden goes straight to these neurological manifestations and is that much closer to this seizure and loss of consciousness phase. Diabetic ketoacidosis, as I mentioned earlier, it is a complication of acute complication of type 1 diabetes or any diabetic who cannot produce their own insulin. In the absence of endogenous insulin, you end up with obviously the hyperglycemia, but also you get this accelerated fat breakdown. And when your body breaks down fat in this way, you end up in this, what's called this ketosis state. The oxidation of fatty acids produces ketones or keto acids, and it gives your breath this sort of sweet acetone smell, and it also induces this acidosis. Okay? So diabetics who are experiencing diabetic ketoacidosis, they are going to be hyperglycemic. They're going to have that polyuria, polydipsia, polyphagia. Okay, they're going to be dehydrated, and they're going to be acidotic. Okay? And if the acidosis gets severe enough, that can lead to seizure and loss of consciousness. Okay? Now, the thing to keep in mind with diabetic ketoacidosis is that when a person has an illness, let's say they have the flu or even just a common cold, it tends to elevate blood glucose. Just that stress of being sick elevates blood glucose. And so someone who has a working regimen of insulin injections, all of a sudden when they're sick, they might need more insulin and they might be more vulnerable to diabetic ketoacidosis. Okay? So again, since this is a type 1 diabetes thing, you're often talking about children. So one of the recommendations that you can read in that chart 51.9 is this recommendation to test your child's urine for ketones when they're homesick from school, because they're much more vulnerable to ketoacidosis than when they are not ill. So assessments with DKA, blood glucose will be usually above 300, could be as high as 1,000. The severity of DKA is not only due to the blood glucose levels, but also the ketoacidosis. Okay? The low pH, low CO2, a person in DKA will often exhibit these exaggerated respirations or hyperventilation that we call Kussmaul's breathing or Kussmaul respirations. And it reflects really this respiratory compensation, blowing off CO2 to compensate for the metabolic acidosis. Okay? You'll see ketones in blood and urine. And measuring ketones in the urine is a very simple thing with that dipstick analysis. You collect the urine sample, put in the dipstick, and it tells you whether there's evidence of ketones or not. Very easy to teach parents to do, or even the patient to do. Electrolytes vary according to the degree of dehydration. You'll often see an increase in creatinine, hematocrit, and BUN. Okay? And it all really depends on the severity of the dehydration. But because of the acidosis, because of the dehydration, oftentimes what you'll see with patients in DKA, depending on how severe it is you'll often see accompanying DKA and acidosis is an apparent hyperkalemia. Okay? So any change in potassium really needs to be treated and treated very carefully. So treatment's going to include rehydration with IV fluids, IV continuous infusion of regular insulin, okay? Reverse the acidosis, restore the electrolyte imbalance. And take note, rehydration leads to plasma volume, increased plasma volume, and a decrease in potassium. So a patient might come in with an elevated potassium, right? Because with the acidosis, all the potassium gets kicked out of the cells. But remember, they're peeing off all of their plasma volume. So their total body potassium is actually low, even though the concentration, when you measure it in the blood, appears high. So when you rehydrate them with fluids, they can easily go from being hyperkalemic to hypokalemic. So And insulin enhances the movement of the potassium back into the cells. So you have to be very vigilant watching the potassium levels. Okay? Also monitor blood glucose and renal function and urinary output, vital signs, lung assessments for any signs of fluid overload, right? So when you're rehydrating the patient, you want to make sure that you're not fluid overloading them. Okay, you don't want to get them all of a sudden with pulmonary edema and respiratory distress. All right, so the type 2 diabetics, they don't get ketoacidosis because they usually have endogenous insulin high enough to maintain their fat stores. But what type 2 diabetics can get is this hyperglycemic hyperosmolar syndrome. Okay? With this syndrome, hyperglycemia can be very, very, very high. Okay? And that hyperglycemia is going to cause that osmotic diuresis, the polyuria, loss of water and electrolytes. You're going to see this hypernatremia because of the dehydration and an increase in blood osmolarity. Okay? And that increased blood osmolarity is from this extreme hyperglycemia. So the person is dehydrated but hyperosmolar. So they're going to have low blood pressure. They're going to be profoundly dehydrated. They're going to have tachycardia. And they may have neurological signs caused by this cerebral dehydration. Okay? They may have a blood glucose level that is startlingly high. Okay? And so this hyperosmolar, hyperglycemic hyperosmolar syndrome unfortunately has a very high mortality rate. Okay? Treatment of HHS, rehydration, okay, because they're significantly dehydrated. Administering insulin is going to help reduce the glucose levels. Monitor fluid volume and electrolyte status. Okay, again, you don't want to overload them with fluid. And really, what you want to do is focus on preventing HHS in these type 2 diabetics. So good blood sugar monitoring, okay? The good diagnosis and management of their diabetes, and assess their self-care management skills. Because HHS is very life-threatening, but it also is preventable, okay? Because everything that a patient does to control their diabetes is going to greatly go a long way to preventing this HHS. Long-term complications of diabetes. Diabetes, no matter what, involves hyperglycemia. And chronic hyperglycemia is particularly toxic to two major tissue types: vascular tissue and nervous tissue. It damages both tissue types. So in terms of the effect on vascular tissue, you see large blood vessels or macrovascular damage, and you see small blood vessel damage or microvascular damage. So on the macro level, the large blood vessels, what you see is hyperglycemia causing atherosclerosis, coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Okay? So you end up with a patient who has a lot of atherosclerotic plaque and therefore poor perfusion to their organs, poor perfusion to their extremities. Okay? Circulation is a problem. Coronary artery disease is extremely common with diabetes. Okay? So you have increased risk for heart disease, increased risk for myocardial infarction and heart failure. Okay? The blood vessels in the brain are also vulnerable to plaque formation. So it increases the risk of things like stroke. Okay? And again, this peripheral vascular disease means that you have impaired blood flow to your extremities. And then microvascular damage means the small blood vessels are damaged under hyperglycemic conditions. And the two tissue types that are particularly vulnerable to this is the retina, which has a lot of capillary density. And so damage to the retina can lead to blindness. And then also the kidneys with those glomerular capillaries, they get damaged over time, and you end up with diabetic nephropathy that can lead to kidney failure. And as we talked about in the renal section, the number one cause of chronic renal failure is diabetes, right? Is diabetic nephropathy. Now, in terms of the effect of hyperglycemia on nervous tissue, it's extremely toxic to nervous tissue. And so what you start to see is neuropathies. So neuropathies are a damage and death of nervous tissue. And what happens is the nervous tissue, the peripheral nerves that are the longest, tend to be affected first. So what you tend to see is what's called peripheral neuropathy, meaning that the sensory nerves that convey fine touch and pain to your hands and your feet, they become dulled. And so people become unaware of injuries that happen, and then they don't take care of those injuries, and the minor cuts can become major infected wounds with peripheral neuropathy. And really this peripheral neuropathy, as I'll explain in a moment, can very quickly lead to loss of limbs, basically, this necessity for amputation. And I'll talk about that in a moment. Another set of peripheral nerves that are affected are the autonomic nerves. So what you often see are people who have orthostatic hypotension because the autonomic nerves that regulate blood pressure are damaged and don't work as well. It promotes that hypoglycemic unawareness because of the loss of the sympathetic nerve function. And then sexual dysfunction is very common, again, because of loss of autonomic nerve function. So what we're looking at here is a really classic neuropathic ulcer. So with diabetes, a big issue is foot care. Okay, for individuals who have chronic diabetes, they're very vulnerable to this peripheral neuropathy, which means that the soles of their feet, their toes, they are not as sensitive. They don't really feel when they get minor cuts, okay? And so what happens is, imagine this person got a really small injury to the bottom of their foot, but they didn't notice it because they didn't feel it. And so they didn't take care of the injury. Now, this person has diabetes and they're hyperglycemic, so that minor injury easily gets infected. Okay? It gets infected because of the poor circulation. It doesn't heal very well. And the first time they notice, or someone notices the injury, it looks like this. It looks like a massive injury now, this ulcer where you have loss of tissue. Okay? Now, if these ulcers are infected enough, the only way to really treat it is to surgically remove the infected tissue and the tissue that won't heal in order to help heal this injury. Now, what's very common is that in the process of removing the either necrotic tissue or the infected tissue, you're left with an even larger injury. The person still has a hard time healing. They're more prone to infection. And so they have to go back and remove more and more tissue. So this person who starts off with this ulcer, they may end up losing one toe and then two toes. And then that turns into a below the ankle amputation or a below the knee amputation. Okay? So this is really how you go from the vascular damage, the nervous tissue damage, to this progressive removal of tissue and leading to amputations. Okay? It's a major problem, and it's really so important. Foot care is really such an important part of diabetes management. Individuals with diabetes are not advised to even cut their own toenails. They actually are advised to visit a podiatrist to get their toenails cut, just to reduce the possibility that they will cut themselves. Okay, so you can imagine that caring for self-care when you have diabetes is just so complicated, and it takes a lot of time and resources, and it becomes a really it becomes a time where nursing care is so critical in order to avoid some of these just terrible complications.